So today is the last scientific session. This is the topic of today. Before we delve into it, I thought maybe we can again sort of give you a little brief overview of what we've covered so far, just to put everybody on the same page and add meaning to today's session. So we started off by maybe like introspecting on the brain, the concept of brain localization, how different regions of the brain do different things, and therefore when these regions are attacked by different diseases, they produce different signs and symptoms. And now I hope most of you understand the difference between signs and symptoms and clinical syndromes. Then we sort of started with an overview of what we call the neurodegenerative diseases of the brain, and then delved deeper into Alzheimer's disease, because as you learned, this is the most common form of dementia in the world. We talked about how patients that have Alzheimer's disease and other forms of neurodegenerative disease, they go through these stages of illness that start even with asymptomatic phases and then slowly progress to more clearly impaired stages of cognition, ending with what we call dementia. And you learn that dementia is a clinical state that can be caused by many different diseases or processes in the brain. And then we touched on a few of the other forms of neurodegenerative diseases beyond Alzheimer's disease that are much rarer but still very important. That we talked about the state of clinical trials, the challenges in clinical trials for these diseases. And finally, we also talked about, what is the evidence around what can we all be doing to protect our brains from this group of diseases, promote brain health, and then talked also about the threat of pseudo-medicine around boosting cognition, preventing dementia, and I hope you had a pretty clear critical look at that topic. So today's session is taking a bigger picture view. We've been focusing a lot on the science and treatments, but we haven't really touched on the global impact of these group of diseases, especially Alzheimer's disease. So that's the theme for today. And for that, I'm going to invite my colleague, Dr. Shamil. She's a primary care physician or a family practitioner in Jamaica. She's one of our Atlantic Fellows at the Global Brain Health Institute, which you're going to learn about more later in today's session. So that's all. I just want to invite you to the podium, and you can get started. Thank
you. Good evening, everyone. First, let me thank you for coming out this Tuesday evening. Unfortunately, I won't be speaking about Bob Marley or Jamaica or reggae music, but I'll talk about something just as interesting. And so today I'll be presenting the burden of Alzheimer's disease and related diseases in vulnerable populations. And to start off, just to give you a refresher that Alzheimer's disease is a degenerative brain disease, and the most common cause of dementia, accounting for approximately 70% of patients. Dementia is not a specific disease, but rather an overall term that describes a group of symptoms. In the last few decades, with demographic aging proceeding rapidly in all regions worldwide, interest began to focus on the prevalence of dementia, in particular in low and middle-income countries. The WHO actually projects that by 2025, about 3/4 of the estimated 1.2 billion people over the age of 60 will reside in developing countries. And therefore, by 2040, if growth of the older population continues, and there are no changes in mortality or burden reduction by preventive measures, this means that 71% of the 81 million people suffering from dementia will be living in developing countries. And this is just a graphical representation of growth in numbers. You can see that high-income countries are in the lavender or purple, and low-income countries in the peach, salmon, very girly colors. But you can see in 35 years, the number of persons with dementia in low-income countries will double that of persons with dementia in high-income countries. So I want to start the talk particularly focusing on dementia prevalence in vulnerable populations with this quote by civil rights advocate Kimberly Williams Crenshaw. And she said, "If we aren't intersectional, some of us, the most vulnerable, are going to fall through the cracks." And I think it's pretty pertinent and relative to where we are now, the fact that so many of us from so many different backgrounds are coming together on a Tuesday night to learn about Alzheimer's disease in vulnerable populations. So with that, let's begin. What is the prevalence of dementia in vulnerable populations? Important to note that the global estimate of the prevalence of dementia is about 5 to 7%. However, there's a lack of standardization procedures throughout the world, and this is actually a major limitation in the estimation of true burden of Alzheimer's disease. And standardization might not be readily achieved because of diversity of language, culture, and levels of literacy. And in some developing and low to middle income countries, more than 80% of older adults cannot read or write. Dementia in indigenous populations, to start, you should know that the term indigenous, there's actually no true definition of indigenous, but persons self-identify as such. And there are approximately 370 million people worldwide who are classified as indigenous. This makes up 5% of the world's population. Only 15 studies have been published on the prevalence and incidence of dementia in indigenous populations worldwide. And this prevalence doubles with every 5.5-year increase in age from the age 60 onwards. The prevalence rate of dementia among indigenous populations is as low as 0.5% to some instances as high as 20%. In general, it should be noted that indigenous populations have lower socioeconomic income, lower education levels, a lower level of overall health, including a higher prevalence of HIV/AIDS, diabetes, hypertension, alcohol abuse, obesity, cardiovascular disease, and mental health disorders, which are all risk factors for the development of dementia. I'm going to take you on a tour of the world. We're going to start in South Africa to a cross-sectional community-based study that was done in low-income, rural isiXhosa-speaking community. It found that 11% of persons over the age of 65 had dementia. Moving over to northern India, India is actually undergoing a rapid demographic change along with a fast-paced social restructuring. It's home to 76 million people over the age of 60, and it's actually estimated that 1.5 million people are affected by dementia in India currently, and this is likely to increase by 300% over the next 4 decades. Several community-based urban and rural studies on dementia from different parts of India documented varying rates from 1 to 3.4% for persons above the age of 60. Moving over to rural Bangladesh, where a population-based cross-sectional study found an overall prevalence of questionable and definite dementia of 11% and roughly 4% in persons over the age of 60. What should be noted about this study in particular is that prevalence estimates are slightly lower than the worldwide estimates, which I said was 5 to 7%. But this could be due to the fact that when this study was conducted, the life expectancy in rural Bangladesh was no more than 64 years. So that could have affected. Moving over to another indigenous population, Aboriginal Australians. They comprise 3% of the Australian population and have some of the worst life expectancy and health outcomes of indigenous cultures within developed nations. Approximately 13% over the age of 60 in urban regions have dementia, and this is actually 3 times greater than the general population. The prevalence and incidence of dementia in remote and rural Aboriginal communities is among the highest in the world, and especially high in younger age groups. Moving over to the Americas, Latin America, the total number of persons over the age of 60 in both Latin America and the Caribbean in the year 2000 was 41 million, and a further 57 million is estimated to join the population by 2025, which is not too far from now. A collaborative study between 6 Latin American countries, namely Uruguay, Chile, Brazil, Colombia, and Peru, found the prevalence rate was about 7%. And in terms of gender, these Latin American studies depicted higher rates of dementia. And in South Korea, the prevalence of all dementia types is about 10%. For Alzheimer's, it's 5%. In Latin America, we see Cuba with all dementia prevalence of 8.2%, and for Alzheimer's disease, 5%. Argentina, 11%, and Chile and Colombia, 4.3% and 1.8%, respectively. But what's interesting to know is that it's not that the prevalence of dementia in Chile and Colombia is so much lower than the world. It's just that in least developed countries, they're less likely to report cognitive decline and social impairment, suggesting that there's an underestimation of prevalence in these countries. Now, in speaking about dementia prevalence or the prevalence of Alzheimer's disease in vulnerable populations, we tend to think of developing countries and low to middle income countries, but also in North America, there are vulnerable populations. And the Chicago Health and Aging Project, which was a longitudinal population-based cohort of adults, 60% who self-identified as Black and 40% who self-identified as white, living in a geographically defined region in the south side of Chicago, found some interesting prevalence rates among Black Americans. Black participants performed worse on average on cognitive tests and were more likely to have prevalent Alzheimer's disease than their white participants at baseline. They were also at a, rather than differences in cognitive decline due to age, are likely to underlie the higher risk of incident Alzheimer's disease among Black Americans. And the findings could reflect differences in cognitive reserve caused by racial disparities over the lifespan in education, both in the amount and in the quality, access to material and social services, exposure to discrimination, and exposure to neurotoxicants. Next section, I'm going to talk about the burden of Alzheimer's disease and other dementias on the economic and social cost. And I found this quote from an American author, which I thought was very poignant to this topic. She said, "I gave 3 years of my life to take care of my dying mother who had Alzheimer's disease. Being there for her every need for 3 years might have looked codependent, but it wasn't because it was what I wanted to do." And I think a lot of caregivers of persons living with dementia share this sentiment. So to understand the social and economic costs of dementia around the world, we should know that a proper understanding of the societal costs of dementia and how they affect families, health and social services, and governments is fundamental to raising awareness, achieving proper prioritization, and focusing efforts to improve the lives of people with dementia and their caregivers. The cost of dementia is distributed unevenly. Just focus on this slide for a minute. We know that 50 million people worldwide have dementia, and that this number will double every 20 years. It costs about $818 billion, and the projected trebling of this figure would mean that 3% of the world's GDP needs to be dedicated to dementia care. It's the 5th leading cause of death, and another way of looking at it is if dementia care was a country, it would be the world's 18th largest economy between Poland and Saudi Arabia, and if it were a company, it would be the world's largest annual revenue, exceeding Apple, Google, Walmart, and ExxonMobil. I know, right? So examining the social cost of dementia, what's different between high-income countries such as North America and low to middle-income countries is that in developing countries, for people with dementia, the state does not provide long-term care. Consequently, the family, particularly patient's offspring, play a vital part in many developing countries. Traditional family and kinship structures are under threat from demographic, social, economic changes that accompany economic development and globalization. An estimate of the worldwide cost of dementia used an average of 1.6 hours of informal personal care per day for all people with dementia. Living with children is the norm, and three-generation households in developing countries, including children under the age of 16, are common. Children can provide food, shelter, personal care, and income for their parents through cash transfers, particularly important in India, the Dominican Republic, rural Peru, Mexico, and China because of very low pension coverage. And I can tell you for a fact that in Jamaica, the average pension is $2,000 a month, which averages out to be $18 a month. Nevertheless, around 37% of people live alone or with a spouse only, and hence can be considered vulnerable. In speaking about the social cost of dementia and Alzheimer's disease, you have to look at caregiver burden. And caregiver burden refers to the overall pressure of caregiving encompassing physical, psychological, social, and financial strains. In East Asian countries, where there's a strong cultural expectation that children take care of their parents later in life, studies have shown that the degree of filial obligation is generally higher than in Western countries. Studies have shown that caregivers tend to experience physical and psychological stress. They are at higher risk of depression, anxiety, and an increase in the risk for physical ailments such as poor immune function and chronic medical conditions. And what's interesting to know about caregiver burden and the changing face of caregivers is that the education of women, especially in developing countries, the education of women and their increasing participation in the workforce, which is generally seen as a positive thing, tends to reduce their availability to provide caregiving and also their willingness to do so. Populations are also increasingly mobile because of education, cheap travel, and flexible labor markets, and children are therefore more than likely migrating to cities and abroad, leaving older people alone. And also, as a last bit, the declining fertility is the last stage of the demographic transition, leaving increasing numbers of older people lacking family support. Now, as it relates to patient predictors for caregiver burden, the lower the patient's daily functioning, the higher the caregiver's burden. The more frequent and severe the patient's behavioral symptoms, the higher the burden. And the higher the sense of obligation, the greater the burden. This corroborates the idea that a stronger sense of obligation by children puts pressure on the caregiver and increases the strain of caregiving. Now, a question I asked when I was doing research for this topic was, is there a difference in the burden that one may face if they're the caregiver for someone with Alzheimer's disease versus other types of dementia? And a study showed that vascular dementia patients in early stages imposed a greater burden on relatives than did patients with Alzheimer's disease. In fact, about 29 to 45% of patients with vascular dementia were under the care of a physician because of illnesses such as hypertension, heart disease, more caregiver burden than those of vascular dementia patients. And anecdotally, caregiver burden varies according to the dementia type. You may have more behavioral issues versus your Alzheimer's disease. But that caregiver burden tends to homogenize in the late stages of the illness. Now we're going to explore the economic cost of dementia around the world. I'll be throwing out a couple numbers, but I'll guide you along. Dementia imposes huge societal economic burden, but through direct and indirect means. Unpaid formal care societal cost of dementia, since it's a producer of an extensive amount of unpaid informal care. And translating the contribution into costs is not straightforward. Quantifying a caregiver's time can be rather problematic. The inputs most commonly assessed are their assistance with basic activities of daily living. This includes eating, dressing, bathing. Assistance with instrumental activities of daily living, such as your finances and your shopping. Supervision and management of behavioral symptoms, and harm prevention. Now, data on direct costs and the distribution between direct and social care costs are available for 21 countries, which is great. This comprises 49% of the worldwide dementia population. And for ease of explanation, direct medical costs include hospital care, medications, and visits to clinics, whereas your direct social care costs are community services such as home care, food supply, transportation, and residential or nursing home care. Now, Table 1 shows the aggregated cost types as percentages of total costs in the different World Bank income regions. Basically, this is just how much does dementia cost in your low-income and your high-income countries. And we can see that for high-income countries, the cost of informal care, which is 40%, and the direct costs of social care, which is 45%, contribute roughly the same proportion to the total cost. Whereas the proportion, as we can see here, the proportion of direct medical costs is significantly lower burden. Next is a table that shows the cost per person with dementia, again by income region. In low and low to middle income countries, direct social care costs are small at 124 and 380. This is millions. Versus your informal care costs, which are significantly higher than your direct social care costs. And to note, in your high-income countries, the total cost per person with dementia is 38 times higher than in your low-income countries, higher than in your low-income countries. What's interesting to note about this is that, again, the proportion of your informal care costs and your direct social costs are roughly the same in your high-income countries, whereas you can see the expenditure for your informal care costs far outweigh those for your social care costs. So again, speaking to caregiver burden. But this table just shows the cost per capita of dementia in billions, by the WHO, the World Health Organization, by global burden of disease region. And again, we're just showing the difference between your low-income countries at 3 points, America at 32 billion. Essentially, this is saying dementia costs a lot. Table 4 shows the contribution of each World Bank income region to the global prevalence of dementia and to the global costs. And about 70% of the global societal costs of dementia occur in your high-income countries, again, your Western Europe and your North America. And 89% of total costs are incurred by these countries, roughly 10% in total. So high-income countries. The current inequitable distribution, and this figure shows the projected increase in dementia will be residing in your low-income, low to middle-income countries in some diseases, and sought to compare like-for-like disease costs with national expenditure on research. And you can see the national expenditure is 48. Cancer, 12 billion, heart disease, 8, and stroke, 5 billion. The reported estimated annual societal costs of dementia, the annual per capita costs were estimated. Investment in research did not match the relative burden of the different, 73,000 pounds, but dementia only received on average 4,800 pounds per million that was spent on care costs. So, into dementia research and equity, or rather, the inequitable research on dementia. And only 10% of studies on dementia are conducted in developing countries. And because of this, the World Health Organization actually initiated a dementia of internationally recognized experts and stakeholders in the specialty of dementia to lead the development of the scope, methods, and implementation of the exercise. And essentially what they did was they assessed certain fields of research on the basis of potential for success, equity, burden reduction, potential for conceptual breakthrough, and translation. And overall, the scores varied substantially. For instance, when considering ranking in the burden of the effect on burden reduction, the scores were highest for the overarching themes of quality of care with dementia and also delivery of care. Whereas for the criteria of potential for conceptual breakthrough, we can see that physiology and progression of normal aging was ranked higher or given more priority. For the equity criterion, the highest scores were for the overlapping domains of public awareness, which is here in white, and for quality of care for people with dementia, delivery of care for services, and prevention, identification, and reduction of risk. And at the end of the policy, what they found, the policy review, what they found was that equity was actually judged to be the least important of the 5 scoring criteria, which is sad. And many researchers actually stated that many research avenues are unlikely to benefit those with or at risk of dementia and their families in an equitable manner. So for all the research that is being done on dementia, only 10% of them have been done in low to middle income countries. And even of that number, the people who probably would benefit the most will probably not likely benefit. But it's not all doom and gloom. I want to leave you with this quote from James Baldwin, who said, "Not everything that is faced can be changed." Off to a good start with all of us being here today. And policymakers are urged to promptly tackle the persistent, remarkable imbalance between the allocation of research funding and resources.
I'm Victor Valschlist, and I run the Global Brain Health Institute and Atlantic Fellow for Equity and Brain Health Program. And we know.
Mission and what do you see for GBHI in the upcoming future?
I think surrounded by Atlantic Fellows, I'm probably not the best person to answer this. The Global Brain Health Institute was established in 2015. We're in our 3rd year. We're training people for 12 months at 2 sites, one at UCSF here, and the second site is in Dublin, where I'm heading tomorrow. We have trained coming in next year, and it'll extend our reach to 37 countries. Dr. Chodos is one of our faculty as well, and so is Dr. Lanata. We're international, as you can tell. We're also interprofessional. So you see clinicians here largely, have health economists, we have policy people, we have writers, we have fiddlers. We have people who are engaged in becoming next generation of leaders to change the narrative around dementia. A public document published two years ago in Lancet told us that 1/3 of dementias are preventable. And so what we need is a public health approach to awareness, decreasing stigma, addressing these preventable factors. And largely low and middle income countries, this has to be an international effort. So we've been fortunate enough to receive funding to hopefully train 600 leaders in the next 15 years on an international scale to try to address this growing challenge and meet the expectations of reducing the prevalence of dementia through these public health strategies.
Fantastic. Great introduction to GBHI. And maybe for Arnold and Lingani, if you can, as fellows of the program, maybe you can share some of your experiences through the program and how they've changed your your focus of things, and what do you hope to do when you return back home?
Well, the focus of my career, I mean, GBHI has impacted my career in so many ways that I did not expect. First of all, particularly the training that I was able to experience in the last 2 years as a fellow. Coming from a developing country and considering Latin America, I mean, it's really difficult and challenging for specialists, and not only in medicine but in science, to be able to come to a place like this and learn and experience and spend time with so much valuable people and persons that are so committed and they inspire you not only through their knowledge but also through their work and all the things that they are doing. So the training is something that is something that I really appreciate, and getting to know the people, because it's mainly all about the people, really. So wonderful people that are part of GBHI. Another thing I would add is the opportunity of networking. As Dr. Balkulda already stated, this is an international group, an interdisciplinary and interprofessional. So the opportunity to meet so many people through our fellowships and build these connections all around the world to collaborate in ways that I really didn't imagine would be possible, could be possible just by working back in Mexico. But now networking has opened so much opportunities. They're just great experience. And finally, I would say that the support that GBHI brings to us through mentoring and through all of these wonderful connections, I think it's something that also has impacted very positively my career being here in GBHI.
Great.
Similarly to what Arnoldo has said, GBHI has had a real positive impact on my career. I feel like having been at GBHI, it's really provided a springboard for my career. I feel like the experience at GBHI has really put me in a space where I can have real impact. As I mentioned before, I'm from Botswana, and I'm the only neuropsychologist in Botswana. So without the experience of GBHI, I probably would have continued to do my work as a neuropsychologist. But being the only one in the country which has about over 2 million people, obviously there'd be many people who go unseen who need neuropsychological services, right? So I feel that having been at GBHI, I've been provided with the space to really think about ways in which I can increase service provision. For example, through conversations with colleagues and mentors at GBHI, I've started to think about ways we can increase the human capacity. So I'm starting to think about having a master's program for neuropsychology. Being the only, we've got one university in the country, and at that university we don't have a graduate program. So one of my priorities is to start a training program so that we can have more human capacity in neuropsychology. Excuse me. And then the other thing that has been really magical, I would say, about GBHI has been the multidisciplinary focus and the multidisciplinary nature of the fellowship. I've been in a space where I have seen the value of being able to talk to people who are outside my area of expertise. GBHI has really illuminated the importance of, for example, knowing the correct conversations to have with policymakers, learning about health economics, for example, learning about grant writing. I think these are all really important skills and things that I've learned to be able to make an impact, because as just a neuropsychologist, it will be difficult to make a bigger impact, but with a multidisciplinary approach, we'd be able to have more impact, I think.
Fantastic. Can you say maybe a few words about how does Botswana compare to other African nations in terms of resources and, the state of dementia care?
Sure. So Botswana is it's a middle-income country. So most of our resources we've been very fortunate in that over the last 50 years, we discovered diamonds in the country. And this discovery of diamonds have seen us move from one of the poorest countries in Africa to being a middle-income country. So we have resources, and these resources have been invested in healthcare. However, the problem is that our healthcare system, the focus of our healthcare system, for example, is on acute diseases, and it's on communicable diseases such as HIV, tuberculosis, and malaria. So there's very little, the healthcare system does not focus on dementia, for example. Just to give you an example, we have, so at the apex of our healthcare system, we have 2 tertiary hospitals. And at these tertiary hospitals, we only have 1 neurologist working in either hospital. So we've only got 2 neurologists in the country. We don't have any geriatricians, for example. No neuropsychologists working in the public system. So as you can imagine, with this backdrop of a lack of specialists, it's the assessment and the management of neurodegenerative diseases is very limited. As I said, we're fortunate enough to have, a healthcare system that is reasonably well funded, although the focus is on acute diseases. But if you compare us, for example, to let me say, so in Botswana, everybody has access to healthcare in the sense that most people will be within about a 5-mile walking distance to the nearest health facility. Whereas in a place like Zimbabwe, it's not uncommon for people to walk for up to 20 or 30 miles to get to their nearest healthcare facility. So although we're better funded, we don't provide services as such for neurodegenerative conditions, but we are better off than countries such as Zimbabwe. And then you heard before in the lecture that there's not very much research happening in developing countries, but places like South Africa and Nigeria and Egypt have been relatively a bit more fortunate in that there's been some research activity in those areas. And given the little bit of research activity, it has meant that care systems have been, I'd say, documented. So that it's been documented what we can do for people with dementia. For example, in South Africa, they have care homes for frail elderly people who are also destitute. However, these homes, these frail people homes, they don't necessarily cater for people with dementia. There are NGOs, non-government organizations, who do cater for dementia. However, to be able to be eligible for these services, you need to be assessed, and families need to pay a certain amount. There's also private services, but the majority of South Africans they can't afford the private dementia services that are available.
Well, thank you for that. And maybe to move on to Dr. Choros, my question for her, I wish I could say that San Francisco has completely taken care of all their healthcare disparities, but that's not the case. And that is true of dementia care, or more broadly, care for people who have cognitive impairment just within the city. The disparities are pretty marked. And I'm always surprised, always shocked, that the San Francisco General Hospital, which is the primary hospital and the network, right, that serves the most vulnerable communities in San Francisco, up to how long ago was the GNCC founded?
2013.
So up to 2013, there was no clinic that was sort of exclusively dedicated to assess, treat, and manage people that had cognitive impairment, which is I think it's pretty shocking to me. So maybe you can tell us a little bit more as to, the history of the GNCC, what you see for the future. This is the Geriatrics Neurology Cognitive Clinic. And if you have to envision, what is what needs to happen to the city, for us to really say that we are providing equitable care in the city, what would that look like?
Yeah, I'm so pleased to have this opportunity, first of all, to be part of this panel and to be part of a larger conversation about equity in dementia care. So I'm a geriatrician, and a primary care doctor most of the time. And part of that has been to develop a dementia clinic at San Francisco General Hospital, but we serve all the safety net primary care clinics, of which there are 12. And we call our clinic Geriatrics Neurology. So Dr. Lanata is also part of our clinic and sees patients there with me and the rest of our team. So it should really be called Geriatrics, Neurology, Neuropsychology, Pharmacy, Social Work, Nursing. So we really, our goal is certainly an interprofessional assessment of older adults for the most part, and by older we mean over 50 for the most part, with cognitive complaints. And when I started it, I was a fellow in geriatrics, and I had done my training at San Francisco General Hospital primary care clinics, and there wasn't anywhere to send a patient that had a cognitive issue. So although I'm misrepresenting things a little bit, I could pick a few things. I could pick neuropsychology, so that means I would have some sort of sense of a specific battery of tests that would help us better understand that person's status. Or I could pick neurology, which of course has extensive experience in all neurologic conditions. However, it was a general neurology clinic. So the thing that you see from the Memory and Aging Center and the Global Brain Health Initiative is really that there is a real specialty and a focus on neurodegenerative brain diseases, which are different than, a very complex set of diseases, as you have learned. And that specialist wasn't there. So with the incredible enthusiasm of another neurologist, Dr. Alexandra Nelson at the Memory and Aging Center, who usually specializes in Huntington's disease and Parkinson's disease and things like that, we started a volunteer service and got our neuropsychology team on board. And so this took what for most patients was either a 6 to 8 month waiting process for neuropsychology, or roughly 4 months waiting for neurology, to a group visit where they would see all of us and get a sense of what we thought was going on that day. And then 4 years later, we were very fortunate to get funding from GBHI to build out that model to include all those other team members. And we're still working on getting our solid footing and funding underneath us. But I think our motivation was really, one, yes, it seems totally preposterous that within your own healthcare system, where you've relied for all your primary care and all your other specialty care, that one of the most prevalent diseases in older people did not have a place to go. And we are taking care of vulnerable people. And so some of the wonderful presentation comments that Dr. McFarland had were that, in vulnerable populations, that's a large umbrella of things potentially, but dementia risk is higher. So we have a lot of people who have TBI for multiple reasons, long history of substance
traumatic
use.
brain injury.
Sorry, traumatic brain injury, which is a risk factor. Longer history of serious mental illness, like serious depression, is a risk factor. And then lower education, so this idea that maybe there's not cognitive decline happening faster, but that they're starting at a lower cognitive baseline, and that's a risk factor. So all of these things taken together meant that we had a higher risk population and fewer services than some of, like CPMC has the Dolby Brain Center, and people who are in the UCSF network or coming from other places could go to Memory and Aging. We did occasionally get some patients over there, but again, we really wanted something to serve our patients. And the reason for that is we have extensive resources available to us that are culturally competent, language competent, and our neuropsychologists particularly also have developed a lot of expertise in many different populations. So I keep thinking when I'm looking at the maps that Dr. McFarland was presenting about the fact that we have people literally coming from those countries to now living in San Francisco, and we're trying to assess them as if their background is the same as the tests that we have to test them with which were created in Montreal or created in New York or something like that. So we've, over the course of a few years now, developed our own series of tests for a Chinese-speaking patient, a Spanish-speaking patient, an English-speaking patient, and then, yes, we have a massive category of other languages, and we're working on it. But we do feel like taking into account the cultural background, the educational background, even within the same country, if that person's from a rural or an urban center, gives you a better sense of really what is going on than a test that you're really forcing into a situation it wasn't meant to be in, or an assessment that doesn't account for all of that. And I think the thing that I'm still acutely aware of is we are just, at the tip of the iceberg stage, and we're really managing to get to the people who either have the best advocates or frankly have fallen the farthest. And now they're in our system in a way that many people, case managers, complex care nurses who are responsible for them and the care that they're getting, a respite center. So people who don't have any housing, who really can't go back to the street because they're too ill. We have something called a respite center. They're one of our best customers. So the respite center is trying to figure out how to help people. Some of the primary care doctors are sort of most engaged with us and are really engaging their patients to come see us. But we know there's a lot of people who aren't coming to see us. And we really want to be able to bridge that gap. And I think the biggest gaps we're seeing still are just access, basic understanding of some of the way these people's symptoms are presenting might be a cognitive problem and not a mental health problem, or not a language barrier, for example. And then the other one is really this overlap of mental illness and cognitive health in our population, and trying to actually, as if we could fit more people into one room. Sometimes it is tough, but get like a psychiatrist in there too, or somebody who has mental health expertise, because we are seeing a lot of that overlap, a tremendous amount. And I, at this point, really can't describe a population for whom it's not worth screening for PTSD. We have a tremendous prevalence of PTSD in our population, and it's a big factor in what goes into thinking about how our patients are presenting to us, what symptoms they're having, and why it may look like a dementia, but is potentially a PTSD issue. So this integration of disciplines, this integration of social services, integration of cultural competency and language competency into the assessment, these are all things we're really trying to work hard on. And a collaboration with GBHI and the amazing expertise that the fellows are bringing from their home countries, of which we are seeing, from which we are seeing many people, is invaluable, because we really learn so much. So they get to rotate with us, thankfully.
Great, fantastic. Thanks everyone for your comments. And I think we can start opening for questions, if anybody has any questions. So we have to wrap things up at 8:30, is what I'm told, because the doors may close. Yes?
Thank you so much for bringing in awareness that I hadn't really considered, that it's a global issue, so I really appreciate that. One of the things that struck me is you talked about educational levels, and I was wondering, is there a way to develop training for people with dementia to have better flexible thinking or responses? So we've taught people 1 + 1 = 2, and that's an educational level. But actually, if you think about it from a design perspective, 1 + 1 = 3, because there's always more than just the 2 parts. There's the unknown. So I was just wondering, if you use design thinking with people with dementia, does it help in that kind of brain flexibility that we have? Neuroplasticity, does it still exist as we get dementia? And can we think about...
Is there anything of value that sort of some form of cognitive stimulation can add to, like, increasing plasticity and maybe... Okay. Anybody want to take that question?
Well, there are 2 important pieces to what is being asked, and I think we commonly will recommend that people stay as cognitively active as they can. We think that there are protective factors with that. I usually tell patients that doesn't mean go home and do Sudoku if you hate doing Sudoku. You don't have to sit in front of a computer and do a computer game. But if you like playing cards, you should play cards. More social interaction, you should say socially engaged. And the science around that is probably not as strong as it is for other things, but it's certainly something that we recommend. There's a flip side to that, though, that needs to be thought of. Well, 2 pieces. One is when you talk about dementia, you're talking about a lot of different things. And particularly around somebody who has Alzheimer's disease, there's often a narrative that you can get the person to do better at something if you just teach them over and over and over. And that's a dangerous narrative for somebody who's having difficulty making memories. because it probably will make the problem worse. It'll increase anger, it'll increase anxiety, and the disease really does not allow somebody to relearn things or to learn things new. So there's a little bit of a risk in kind of this blanket statement that if I work really, really hard, I will make this person better. So I try to make sure that that's not a narrative that we're sharing. The education around it, understanding it's the disease, there are certain things that they will not be able to do, and trying to force a teaching around that can be dangerous. So I think that I think about it in two different ways. The opportunity is really probably around low literacy before the disease begins. And so the data on if you have good education in early life, there's pretty good data that you will be less likely to have the clinical manifestations of dementia in late life. And so these have been done in beautiful studies around, believe it or not, nuns who you could go back. Mother Superior said you can have all the brains. And so we knew who had Alzheimer's disease and not, and went back to the essays they wrote when they entered the convent. And based on the complexity of that, you could tell the risk for developing dementia. So we think there's good evidence for early life treatment, but we don't know about late life literacy. So around the world, many, many people are illiterate. And can you train literacy at 60 years of age to protect? It's a topic that one of our fellows is working on. I think that's a big opportunity, is even within this audience, once you retire, staying cognitively active, staying cognitively engaged is probably protective. So those are the opportunities, I would say.
Great. Yes, question right here in the front.
The picture that's presented is very, very grim. And, I'm sitting here and the numbers are just horrendous. There's hope, obviously, the GBHI, but I mean, 300 people going out into the world. Do you guys have hope? I mean, seriously, this just seems so dismal.
So the comment / question is around hope, and given how grim the future looks statistically, how do we hold on to hope? And anybody want to take that question? I think
I'm just gonna my piece on it. I think that there is hope. There is hope at these. I mean, as a fellows, we have like this positive attitude towards we can make a change happen. I mean, small contributions eventually will lead up to to a bigger effect. And there's so much people beyond GBHI that's also interested in this. And as I said before, the opportunities to meet these other people and to build ways to collaborate and to share and inspire through getting to talk about what our current problems are, our local problems, and then discover that we're not so different from other countries that are experiencing the same problems. And the ways that we can engage in just collaboration that can actually help do something to improve the way that we care and we treat and we diagnose and we help people that are living with dementia worldwide. I think that there is hope. Of course, it's a big challenge. But big challenges demand big efforts, and so there's people who are willing to, go up to the task. So yeah, I think there's hope, at least from my point of view.
And I was just going to add a slight comment to that, and I think the biggest hope would be the fact that we know that some of the preventable risk factors we can do something about. So if we target that, things like physical exercise and eating a good diet, social interactions, and so forth. So I think this would be the environment that we can target for hope against dementia.
And just something that you mentioned struck a chord with me. In Mexico, we have a fellow who works in the ER, and if you have a stroke in Mexico, you're likely to get to a hospital, I think he said 3% of the time, in time to get treatment for the stroke. And if you get to the hospital, about 3% of people actually get the treatment. So there's a huge gap, and stroke is really one of the leading factors for developing dementia. If you have a stroke, your risk goes up tremendously. So in a lot of the regions, there are great opportunities, huge opportunities to have impact with a very powerful leader who has the drive to change networks and systems within country. And I think we hear about these opportunities with our fellows with some frequency. So I think that gives me hope.
I think for me, there certainly is reason to hope. So maybe we can't prevent all people getting dementia who are going to get dementia. And I think you're also seeing that there's a really broad approach to prevention and sort of reducing the number of people who get dementia. But I would say hope for me is when I see someone who does have dementia, who's getting the right support, who has a good quality of life, who has a caregiver who feels supported and has skills, and that is doable. That is very doable. And I think part of the change will be people who don't have dementia yet, because people who do often, and caregivers who are really in the thick of it, often have a lot on their plates or aren't advocating well for themselves. But it's the rest of us advocating for better care for those people, knowing that it may be us one day as well, but also because it's, you know, it's the right thing to do and it's a better society to live in. But it's not a necessarily something terrible. It's the way a lot of people have to muddle through it that is really terrible. So that for me is hope. I mean, I have a lot of people I work with who are doing very well, and yes, they have dementia. But, you know, that is one thing I hope for.
And along these lines, I also sometimes think that, you know, given the magnitude of the impact of these group of diseases, I think it's almost like it's going to push us at a worldwide level to really like think of our brains in a very different way. I don't know how to put this. You know, the impact of dementia at a societal world level is huge, but at an individual level is also huge. And that's going to put a new sort of, in my opinion, I think in the long run, a new focus on the brain, which may jumpstart a movement around brain health more broadly in the setting of the world that we live in right now that is so tightly interconnected through social media and technology. That could exponentially cause changes for the better, I think. I hope, you know, through awareness. So that's why one of the missions of GBHI is just awareness, you know, educating, making people aware of this. I mean, I'm thinking of nations and regions of the world where somebody has, you know, the clinical symptoms of one of these neurodegenerative diseases, and that society will contextualize that as, I mean, frankly, demonic possession, right? So we gotta work on that, and in order to start to make really powerful changes. Any other question? Yes, sir, in the middle, back.
Yeah, this is a question for Dr. Farling. I was really these diseases on the caregiver, the family, a little bit about how China, which is relative, how is China dealing with this, the burden on that there are expected to assume most of the burden, and China's a relatively wealthy country.
So the question is, how is China dealing with caregiver burden? Anybody want to, you have any comments around that?
So there's a Confucian philosophy called filial piety that speaks to this filial obligation where children or the caregivers are sort of like the silent, they're not the ones suffering from the illness. And so they, as I mentioned, they deal with anxiety and depression and chronic medical illnesses. And in Asian countries, and I think globally, even if it was your husband's parents, you would still take care of them. Great, but then it sort of leaves the void that, well then, are being conducted now on caregiver burden, and how do we address this issue, and that it shouldn't just be an issue for young girls growing up, that this is what you're supposed to do. We have to do with the wealth of a country when it comes to informal caregiving. As I don't know if you remember from some of the tables, the informal care was vastly different from the direct social care costs. So as a child, I am acutely aware, and again, from the culture that I grew up in, I'm acutely aware that I am going to have to take care of my parents when they get to that stage. And it's something that I think a lot of us have to deal with on a daily basis. But in terms,
yeah, and I want to add to this is a huge challenge. I think going back to this interconnected type of model, you see sort of a dissipation. I grew up in Peru, and it's very common for grow up in a city, then you can hang out there for a long time, but that's changing because people like myself, I left not only my country, but not only my city, but my country, right? And I left my parents behind, and that's happening more and more, I think, throughout the world. And here in San Francisco, I think we all see this a lot. We see a lot of patients that are elder and alone, elder and disconnected from family. Families maybe within the state, but they're not seeing them. And that adds incredible burden, and from a provider perspective, to come every day to help with her husband, because she is also elder and frail herself, and she cannot really help her husband ambulate, or so she needs constant help. So that's a ballpark figure, right? And then the cost of having a loved one go $1,000 a month. Right? The range would be what, 4 to 12, depending on the quality. That's the other part of this, that there's no. Yes, sir.
A question about the slide from chronic. It was showing projections of dementia in various countries around the world. The numbers for Australia seem like incredibly small compared to the other ones. Do you have an explanation for that?
That was not a national figure.
And I think that opens up a lot of methodologic concerns, I think, in terms of appropriate techniques for detecting this as always.
Yes. So indigenous populations and injustices and traumas, and culturally they're different from even doing it in San Francisco picture. So it's finding tools. So it's very hard to determine the prevalence of dementia in a lot of these indigenous populations because of cultural differences, language differences, and just also sometimes these persons are untrusting of Westerners and what are you doing with me in my country? Mm-hmm. So these are all estimates, and as you can see in indigenous population, probably impossible, to as high as 20%. It's such a large range, we just don't know, again, because we don't have tools that will cater to all these different cultural differences.
The element of sexism in some of the policy changes that you're trying to make. And I may be wrong here, but I'm thinking that many of the policymakers are male, and the effects for caregiving and women having dementia more frequently.
Oh, the question is if we've thought of how sexism may be influencing policy changes around dementia throughout the world?
I don't know about the world. I would say that, so there's no doubt that the burden of this falls harder on women in both regards, that more women get dementia, probably care for somebody with serious chronic illness and or dementia, and then get it themselves. And then the burden of caregiving falls more on women. And so it's clearly related to lower income later in life and poverty later in life for women, force engagement, formal workforce engagement because of a child caregiving scenario, and later other family caregiving scenarios. So it's extremely relevant to the question. I think I frankly haven't thought of it through that lens. What I was going to say is actually ageism is a big problem that we have because of sort of internalized ageism and societal ageism around these issues, and sort of if I don't look at it, I don't have to think about it phenomenon. And one of the most startling figures I saw recently was there is, I don't even know what it really is, an anti-aging medical society of some sort. And I belong to the American Geriatric Society, which is medical people who do clinical medicine for older people. And we have about 6,000 members. They have 26,000 members. So
Wow.
once we get to an even ratio, I'll feel a little bit better about the state of ageism in our country. But I think it's just a general phenomenon of not wanting to look at this issue, whether it's because of it's a woman's issue or because it's a older adult issue. But I think it's a really important question, and I promise to look at that after this evening. And I don't know about more globally.
You've touched on this conceptual issue that is just so prevalent, right? Like only a few societies, I think, have really confronted this issue of aging and everything that comes with it, like head on, I feel. I don't know the data around this, but this is my subjective feeling. But for the most part, and I think this is true of Peru as well and many Latin American countries, it's sort of like these issues are just bundled up as part of like retirement or, old age, and the minutia is just not looked at. It's just like you got to figure it out as a family, as an individual. Not my problem is what most governments and societies say, and that's problematic. You had some comments.
I'm not sure of the statistics now, but I'm very hopeful for the future, because this Atlantic Fellowship has so many remarkable women in leadership positions, and they are preparing us to go to our countries and give us a seat at that table so that we will be able to influence future policy decisions. So I'm hoping that 10 years from now, women will play a more active role at the higher levels due to at the Atlantic Fellowship at the very least.
And 80% of these emerging leaders are women.
Yeah, that's great. That's an accomplishment. Yes, question here in the back. We have time for a few more questions.
Just a quick question on practicalities. You've had 6 wonderful presentations over 6 weeks. You have an extraordinary comedian coming in for your 7th week. I'm asking, with these 2 technology-inspired gentlemen behind us with their cameras madly photographing all of this, where can we find this? Where can we go to see, for instance, I missed last week's lecture. I'd like to watch it. Where can we go to
Right, so all of these lectures are being recorded, and they're going to be uploaded into the UCTV website, is what I'm told. So you'll be able to watch them as many times as you wish. Any other questions? Yes, sir.
Yeah, I was, I mean, this is actually 2 things. First off, I'm wondering if there are epidemiologic studies that have been done that might suggest that that caregivers actually are preventing Alzheimer's from occurring.
In themselves, you mean, or in a, no?
Cognitive load.
Actually, I don't know if anybody wants to take that question, but it's quite the opposite. Caregivers, unfortunately, are at higher risk of developing cognitive decline themselves, even if they start off being very healthy. And in other words, the role, the burden of being a caregiver, and we've shown this in our work, poses a risk for dementia later in life.
Okay.
Yeah.
And then secondly, I was just curious about the brain, or the group, the brain,
The Global Brain Health Institute?
Global Brain Health Institute.
Yep.
Are you just looking at Alzheimer's disease, or are there other, I know you had mentioned TBI, and do you have data on TBI, for example?
So the question is, does GBHI look only at Alzheimer's disease, or is it a more broad scope? Maybe you can answer that.
No, it's much more broad than that. It's a brain health protection strategy, and so TBI, Lingani is working on a TBI intervention in Botswana, because people who get traumatic brain injury if they do not get cognitive rehabilitation, are at a very high risk for dementia. So if you can just introduce cognitive rehabilitation to people who've had traumatic brain injury, you can have a large impact. A doctor in Mexico, Hieronymo, looking at stroke. Can you prevent stroke as a brain protection strategy? Elisa Rezende from Brazil is looking at late life literacy training to see if you can train late life literacy to prevent all types of dementia. We have many people studying palliative care in dementia, in fact. Can you help people access services when they have dementia? Right now, if you have a dementia diagnosis, the likelihood that somebody is thinking about your quality of life in a very systematic way is not very good. And if you go as far to the idea of hospice, which is a benefit in the United States, in the last 6 months of life, the people with dementia almost never access that benefit because the laws require that somebody certify they have 6 months left to live, which is very difficult to certify when you have a dementia diagnosis. So there's a very broad range of what we're trying to do to help people with dementias of all different types, but also to prevent dementias of all different types.
Has anybody looked at these issues of prevalence of dementia, preventable lifestyle elements, etc., in the Scandinavian countries where there's a rich network of social services and well-educated people to compare to some of the other examples that we've heard about tonight?
I'm sure it makes caregiving a lot easier to have a society that is thinking of elders.
So much research has come out of those countries, and unfortunately I can't speak to them in specifics, but some of the best studies, particularly around prevention, have come out of those countries. Not only do they have systematic resources, but they have systematic data collection. So it's quite easy to understand the prevalence of disease, interventions for disease, and so there's a lot. Unfortunately, I can't speak to the specifics. Maybe somebody here knows the data better than I.
No. Yes, question in the back.
So you talked about a variety of vulnerable populations, but I didn't hear any talk about individuals with intellectual and developmental disabilities, which is a tremendously vulnerable population.
Yeah. I spent the weekend reading a pilot on that and trying to provide feedback for one of our fellows who's in Ireland, who studies Down syndrome. People with Down syndrome have a 100% likelihood of developing dementia by the age of 60. I'm learning a lot of these statistics by reading her application and really the challenge, and also the challenge of accessing therapies, accessing diagnosis. Intellectual disabilities creates an entirely new set of challenges around how you identify change in somebody's cognition, many times relying heavily on behaviors. People with Down syndrome don't have access to clinical trials. There are a lot of barriers. So yes, we agree this is a population, and we have, of our 85 fellows, I'm thinking 2 fellows are specifically looking at intellectual disabilities, one in Barcelona and one in Dublin. Yeah. Any other thoughts?
We've had some patients who it's been sort of unclear what their baseline is. In fact, one of the questions is, does this person have a developmental, have they had it their whole life? It's sort of haunting them in their chart, so somebody puts it in there, and now they're in their 60s, and it's just one of these, also a testament to how bad our medical records are, really. But so people who have not had an intellectual or developmental disability and not gotten great care over their lifetime either, we've had some challenges with that. But really the question for us becomes, what's their baseline? Who can help us figure out how well they were doing at some point? And then where are they now compared to that? And one of the things I've really learned as well is the vulnerability of those folks. So we already know that people with dementia are way more likely to be exploited or subject to elder abuse. And in this case, a case of a woman I saw today, in fact, she's in a really tough situation because she's been dependent on other people for her legal stuff and financial stuff her whole life. And that's been something that the person who she's been relying on has really sort of dropped out of the picture. And so there's almost legal complexities that are on top of all this that we weren't really prepared for. So I think also with the growing incidence of some intellectual disabilities, and I may be off on the standard terminology now, but atypical neuro development, like autism and spectrum disorders. I think it's going to be a bigger issue in terms of a more comprehensive strategy. So it's a great question. It's very real. It actually comes up all the time.
I think that's all the time we have. Thanks so much for your attention and participation.